I want to go to Ted for a second, only because when I talk to oncologists, and again, you represent so many in the work you do with COA, the Community Oncology Association, and I bring up issues like palliative care, and they say, I'm an oncologist. I treat pain. That is part of my job. It's what I do. I don't need to refer the patient to another doctor to do the thing that is part and parcel to my everyday work. And it does, and so the echo I'm hearing from them is, why do we need another specialist? We already have a surgical oncologist, a radiation oncologist, a medical oncologist. Now we need a palliative care specialist. So there is this pushback I'm hearing from the physicians that this has gotten out of control, that somehow they lack a skill set when they believe that that's exactly what they do, and that they think it's much more cultural and complex, and it's not just a simple physician issue.
Well, I think, frankly, let me say, first of all, again, I'm on the short end of the stick, not having an MD after my name, but I am married to an oncology nurse. The bottom line is it comes back to patients. And what I was going to say, Bruce, is I think, first of all, I think it has to be built in not only to the oncologist, if you will, and no, it doesn't have to be taken out that everybody's referred to a palliative care specialist, but I think it has to be built into the fabric of the practice. In fact, I think this takes us back full circle to what we talked about to begin with, which is the focus on the patient. And I think it's incumbent not just on the oncologist, and I think the oncologists have to do more in that area, and I agree with Mike, even not being the physician, that you talk about all those different things, and they are separate, but I think it has to be built into the fabric of the practice, and it's the oncology nurse, it's everybody who touches that patient, who contributes back to the idea of what palliative care is really about. A lot of people say palliative care and they think of end of life. That's not it. Obviously, and again, I'm not the physician. This is about the quality of life of the patient. And I think what happens too often is because there's this drive, and a lot of people accuse it's the oncologist who's always treating, no matter what. A lot of times it's the patient who's coming in who's saying, I want to be treated, I want to be treated, I want to be treated no matter what. Or better yet, it's the 92-year-old woman who's just, the grandmother who's fine, but it's the grandson who wants to push, no, we've got to keep grandma around. And so what happens is there's less of a focus on that person, that individual, their quality of life, as opposed to the treatment side. So I am a big believer that this has to be built into the very fabric of oncology practices, not just resident with the oncologist, but certainly not pulling it out by, there are cases where you need a specialist in terms of palliative care in certain really tough situations, like anything in life, that are really unique. But in this case, I think regular palliative care has to be built into every oncologist, but into the fabric of the practice.